We'll discuss the mechanism of arrhythmia, where it is important to know the mechanism, because when we deal with the ECG in a patient with arrhythmia, we should know what is the underlying mechanism of that arrhythmia. Second, based on the mechanism, we should know what treatment we have to plan. So let's start this topic. So we know this is the conduction system of the heart. It consists of the SA node. From the SA node, the impulse goes to the AV node via the three pathways, that is the anterior, middle and the posterior internodal pathways. And from the AV node, we have something known as the bundle of His, from where it divides into right bundle and the left bundle. There is no division of the right bundle, whereas the left bundle divides into left anterior fascicle and the left posterior fascicle. And through these fascicles, we know that the conduction, it goes towards the endocardium to epicardium via the Purkinje fibers. We know that the highest velocity is present in the Purkinje fiber, and it has the lowest refractory period. Conduction velocity at the Purkinje fiber is around 4 meters per second. But that is the anatomical point of view. Let's go to the physiology and the mechanism of arrhythmia. So we know, as compared to the atria, there is a difference in the ventricle, that the activation in the atria, it is longitudinal. So there is a sequential and longitudinal activation in the atria. This is in comparison to the ventricle, where it traverses tangentially, that is a transverse section, and it goes from the endocardium to the epicardium and from the apex to the base. And that is why we usually see that the atria usually enlarges and the ventricle usually hypertrophies. So this is one of the important difference between the activation of the atria and the ventricle. And because of the dilatation of the atria, it is usually more prone for arrhythmias. Now let's come to the most important thing about the cardiac action potential, because the mechanism of arrhythmia lies in the phases of the cardiac action potential. We know there are various myocytes, like the atria myocyte and the ventricular myocyte, then the bundle of His and all the bundle branch and the Purkinje fibers have their own action potential. But it is very important to know that apart from this, there are various pacemaker cells that are present in the SA node. So these are the pacemaker cells which have a different properties, unique properties comparing to that of the atria and the ventricular myocytes. So we know that in the ventricular myocyte there are 4 phases. So let's see these phases one by one. Now we know the ventricular myocyte has a resting membrane potential of around -90. So the resting membrane potential of a ventricular myocyte is -90, which is usually maintained by the sodium ion. Now there are various phases like phase 0, phase 1, phase 2, phase 3 and phase 4. Now why these phases are important? Because each of these phases contributes to the ECG, means each phase contributes to the segment of formation of the ECG. Now the phase 0, that is a rapid depolarization, is because of the activated sodium channel. So what happens is, when the resting membrane potential is at the -90, the sodium channels, which are at 3 states, that is the inactivated, activated and deactivated. These are the 3 states of a sodium channel. So it gets activated at around -90, and rapid, that is a sharp slope is there. All the sodium channels go inside the cell and it contributes to the phase 0. So whatever was negative inside, it starts becoming positive, and all the sodium ions goes inside and contributes to the phase 0 of the action potential. Now what is phase 1 is, in the phase 1, whatever sodium channels are there, to equalize it, some amount of sodium channel goes inside the cell. So the closing of the sodium channels at this stage is formed by the phase 1 of the action potential, and here the sodium ion closes off. Now next movement is the importance of the potassium ion and the calcium ion. Now what happens is, here the depolarization is over and the repolarization will start. So phase 2 to phase 4 is the importance of the repolarization. So phase 2 is, we have both the potassium channels open and the calcium channels open. The calcium ions goes inside the cell, and the equal number of potassium ion goes outside the cell, and that is why there is a plateau in the phase 2. So the calcium ions goes inside and the potassium ion goes outside. So as there is an equilibrium, the phase 2 is a plateau phase. Followed by this, there is a phase 3 where the potassium calcium channel usually closes, and it is only the potassium ion which exits from the cell. So because the calcium ion channel closes, all the potassium ions go outside the cell. So again it goes towards the negative side, and that forms the phase 3 of the action potential. And finally we have phase 4, which is again due to the potassium ions. Phase 4 is by the potassium ions, which maintains the state of equilibrium. That is the phase 4 of the action potential. Now, as I already told you, there is 3 types of state of a sodium channels: deactivated, activated, and inactivated state. Now, this is the thing which we discussed, that is a ventricular myocyte and even the atrial myocyte and a bundle branch and a Purkinje fiber action potential looks a similar way. However, this is in comparison to the SA node. These are the pacemaker cells of the heart, and the action potential of SA node is totally different from the ventricular myocyte. Why? Because unlike a ventricular myocyte, it doesn't have phase 1 and phase 2. So this upslope is formed by the phase 0, downslope is formed by the phase 3, like that, and this is the phase 4. Now, a second important difference is it is not the sodium channels which forms the phase 0 here. It is the calcium channels. So the movement of calcium inside the cell leads to the phase 0 in SA nodal cells, whereas the phase 3 is same like a ventricular myocyte. The down phase is formed by the potassium channel which moves out of the cell, and finally the phase 4, unlike in the ventricular myocyte where the phase 4 is formed by the IKR, like the potassium movement, potassium channel, the phase 4 of a SA nodal cell is formed by the calcium ion. So these 3 are the important difference between a atrial and a ventricular myocyte and the SA nodal cells. That is the action potential. Now let's revise this once. So as I told you, the phase 0 is the rapid depolarization which is formed by the opening of the fast sodium channels. Phase 1 is the initial rapid repolarization, and it is because of the closure of the fast sodium channels. So phase 0 and phase 1, it is the depolarization almost. So it is formed by the R and the S waves of the ECG. Now next is the phase 2, that is the plateau phase. It is a balance between the inward movement of calcium and outward movement of potassium, and it corresponds to the ST segment of the ECG. That is why we tell that most of the things which act on potassium, where any potassium blocking agent or if class 1A or class 3 agents, anti-arrhythmic agents, leads to prolong the duration of the action potential, and that is where the importance of that is. So it corresponds to the ST segment of the ECG. Phase 3 is the repolarization. It is due to the potassium channel remains open, the calcium channels are closed, and it corresponds to the T wave of the ECG. It corresponds to the T wave of the ECG. And finally, we have the resting phase, which is associated with the diastolic portion of the heart cycle, and it is the potassium outward current through open inwardly rectifying potassium channel. So it is formed by the inwardly rectifying potassium channel, the phase 4. So these are the various phases of the action potential. Now comparing the ventricular myocyte to the pacemaker cells, as I already told you, phase 0 is formed by the calcium influx, phase 3 is formed by the potassium exflux, and there is no phase 1 and phase 2, and phase 4 depolarization is due to the calcium ion. So these are the importance of the various phases. Now as this diagram depicts the same way. This is the SA nodal cell, and these are the atrial muscle. Then we have AV nodal cell, which is just mimics the SA nodal cell, the cardiac action potential, and all others have almost the similar shape of the cardiac action potential like the ventricular myocyte. Now this is one important thing, that is the refractory period in cardiac cycle. Now this is the ventricular myocyte. Now there is something known as the absolute refractory period, effective refractory period, and relative refractory period. Now what is an absolute refractory period is? It is the refractory period. It is the time where the cardiac myocyte does not allow any depolarization. So whatever the stimulus may be, it won't be able to induce a depolarization. Now followed by that, there is a effective refractory period where a non-propagated depolarization can happen. It can depolarize, but it will be non-propagated. Then we have a relative refractory period. So relative refractory period is the time where the stronger than the normal stimulus can cause a depolarization. So only a stronger than a normal stimulus can cause a depolarization. And finally, we have a supranormal where even a weak stimulus can cause an action potential. This all things are usually related to the physiology, and it doesn't have much of the importance except in relation to the ECGs and electrophysiology. Now let's discuss the important thing, that the mechanism of arrhythmia. Now most of you will be very confused because these are the very important things, and we tend to sometimes not understand it, and we tend to just read it for the exam, following which we will have a tendency to forget it. But if you do not remember the mechanism of arrhythmia, it is very difficult to first understand the ECGs, understand the mechanism why that arrhythmia has happened, and to know how to treat that arrhythmia. So the various mechanisms are, one is the it can be divided into abnormal impulse generation and abnormal impulse conduction. If it is due to the abnormality in impulse generation, then either it can be a triggered activity, which will I come into, or it can be a automaticity. Automaticity is a characteristic of the SA nodal pacemaker cells. So we should know that it has to something to deal with the pacemaker cells. Whereas if it is an impulse conduction, then it is the issue is the re-entry. We all of you would have heard all these things, but I'll just discuss in detail each of this so that we understand the basic electrophysiology of the heart. So let's come to the automaticity. So as this slide shows, the automaticity can be reduced automaticity or a enhanced automaticity. So what is the automaticity? It is the property of a fiber to initiate an impulse spontaneously without the need for prior stimulation. So that is one important thing. I'll just give it an example to this. We know that the mechanisms like the re-entry, that various arrhythmias in re-entry like the AV nodal re-entrant tachycardia, it needs a stimulation. That stimulation can be either a atrial premature complex or a ventricular premature complex. So it needs an initial to impulse to initiate it. This is in opposite to the automaticity, where it doesn't need any stimulation. Why? Because the pacemaker cells of the heart, that is the SA node pacemaker cells, they start stimulating itself. Like we have both the type, either the normal SA nodal cell, it causes inappropriate discharge, or there can be an ectopic pacemaker. So this thing is very important thing. So either the normal pacemaker cells of the heart, it starts to discharge abnormally, or there are abnormal pacemaker cells. So suppose in example, in many times in ischemia and all myocardial infarction, the various ventricular myocytes, they start behaving as a pacemaker cells. That is, they become the ectopic cells. They start behaving and get the property of a pacemaker cell, and they start showing the property of automaticity. So it is characterized by either an inappropriate discharge rate of a normal pacemaker, that is the SA node. It starts discharging either very fast or very slow, or the discharge of an ectopic pacemakers that controls the atrial or a ventricular rhythm. And this ectopic pacemakers are known as the latent or the subsidiary pacemakers. Now we know that the ectopic pacemakers are usually suppressed by the overdrive suppression. Now overdrive suppression by the more rapidly firing SA node, or by the concealed conduction through the neighboring fiber, and they are manifested only when the sinoatrial discharge rate slows. So this ectopic pacemakers will manifest only when the SA nodal discharge rate is slowed, or block occurs somewhere at the level between the SA node or the ectopic pacemaker site. And the discharge rate of the latent pacemaker can speed inappropriately and cause the firing. Now I will just give the example. like this is the abnormal automaticity. So it is the creation of the electrical impulses by the non-pacemaker cell. As I already told you, sometime what happened in the myocardial ischemia, that the non-pacemaker cells of the myocardium, they acquire the automaticity and they spontaneously depolarize. And this happens because of the phase 4, the slow inward calcium channels. Because we know that in the in the vicinity of the myocardial ischemia, there is a decreased sodium potassium ATPase. When the sodium potassium ATPase is decreased, it causes the increased release of the calcium channels. Now, when the calcium channels are increased, it drives the maximum diastolic potential towards the threshold potential. Now, it is the threshold potential where any cell, that is either the ventricular myocyte or the pacemaker cell starts depolarizing. So this calcium will cause the maximum diastolic potential towards the threshold potential, and it starts the phenomenon of automaticities. Now this is the example. This figure A is the normal automaticity. These are the pacemaker cell. This is the normal automaticity. Figure B is increased threshold voltage. You can see the threshold voltage which was here now has started to discharge before only. So this is the enhanced automaticity. C is the decreased membrane diastolic potential, and D is the depolarization. So you can see early depolarization has started to happen. Now the most important thing is you should know that most of these arrhythmias are regulated by the sympathetic activity. We know because whenever the increased sympathetic activity is there is increased release of catecholamines like the calcium and all. So the sympathetic nervous system causes increased automaticity, whereas the parasympathetic nervous system, what happens is when there is an increased parasympathetic nervous system, there is a hyperpolarization which causes the exit of the potassium out of the cell, and that is why it decreases the depolarization, and that is why parasympathetic decrease the automaticity, whereas the sympathetic thing increases the automaticity. Now the examples of the arrhythmia which are through the automaticity are, one is sinus tachycardia. The most important thing is inappropriate sinus tachycardia or appropriate sinus tachycardia are both due to automaticity, and this is the reason why exercise causes the increase in sinus tachycardia, whereas the vagal tone causes a sinus bradycardia. Now second is ectopic atrial tachycardia. Now ectopic atrial tachycardia, as the name suggests, it is due to the ectopic or the latent pacemaker. It is the latent or the ectopic pacemaker which starts discharging and which causes the ectopic atrial tachycardia. This ECGs will discuss in the further classes, how do they look. And then third thing is the junctional tachycardia. So third thing is the junctional tachycardia, which is important. Now you should know few things before. The one important thing about automaticity is one which I already told you. As compared to the re-entry, they do not need any extra stimulation like the atrial premature complex or a ventricular premature complex. And to induce this during the electrophysiological studies, you need something known as the programmed electrical stimulation, which gives a extra stimulus. So automaticity doesn't depend on the extra stimulus. Second important thing is in the automaticity, there is a warming up and cooling down. That the rate of acceleration at onset, there is a slow increase and then it builds up, and even when it stops, it doesn't stop abruptly, it stops slowly. So there is a warming up and the cooling down, and that is why many patients who get sinus tachycardia, when you ask them clinically, they'll tell that their rate, it doesn't start very fast, it starts slowly, tuck 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 tuck. So it builds up, and when it stops also, it stops gradually and not suddenly. So this is one important thing about the arrhythmias due to automaticity. Second is it responds to the sympathomimetic and autonomic modulation. That is what I just told you. Sympathetic nervous system increases and the parasympathetic nervous system decreases it. So this is the normal automaticity. You can see that there is a normal automaticity. Now one important thing about the normal automaticity is there is something known as the overdrive suppression. I don't know many of you would have heard this or not. Suppose in your ICU, if some patient is having a some arrhythmias like a ventricular tachycardia at a rate of 150. Now there is one way to stop that arrhythmia is you put a overdrive suppression, that you put a temporary pacemaker to that patient and you pace that with a rate more than the VT rate, that you start pacing the pacemaker at 200. Now what will happen is it starts producing a overdrive suppression. Now because this overdrive suppression is when this rate becomes more than your arrhythmia rate, there is a suppression of the arrhythmia by automaticity, and that is known as the overdrive suppression. Now, as I already discussed, the parasympathetic activity causes the hyperpolarization by increasing potassium exit from the cell, and that is what you can see, that there is an increased potassium exit from the cell, and this is this thing. And the sympathetic nervous system, what it causes the increased inward flow of calcium and the sodium, and there is a rapid phase 4. You can see this dotted lines. There is a rapid phase 4 depolarization. So this is what is the effect of sympathetic nervous system. Now let's see this ECG. Now once you see this ECG is a patient who is exercising. During an exercise, you can see there is somewhat narrow QRS type of tachycardia, and here is where the exercise was stopped. When the exercise was stopped, the sympathetic activity goes off, and the asterisk places where you see that there is a that the P wave has started to come. Now this is the cooling down period. Now you can see it takes this much time for the arrhythmias to settle, and that is why we told that automaticity there is a warming up and cooling down period. Here the exercise was stopped, and it takes this much time for the arrhythmias to stop, and the P wave has started coming. So this is one of the important thing about the automaticity. Now other examples of enhanced automaticity is paroxysmal atrial tachycardia with block. This is usually seen in patients with digitalis affect or digitalis toxicity. We see that they have paroxysmal atrial tachycardia with block. And even in patients with COPD, what we see known as multifocal atrial tachycardia is due to the enhanced automaticity. So the examples involve sinus tachycardia, both appropriate and inappropriate, junctional tachycardia, ectopic atrial tachycardia, paroxysmal atrial tachycardia, and multifocal atrial tachycardia. So all this atrial tachycardia except atrial fibrillation and flutter, which are due to the re-entry, all these atrial tachycardias are due to the enhanced automaticity. Again, the same example I also see. This is a patient who has a multifocal atrial tachycardia. You can see, you can see that there is different morphology of the P wave, and that is why it is a multifocal atrial tachycardia. It is seen in patients with usually COPD and rarely in heart failure. Usually responds well to calcium channel blocker. You cannot give beta blocker because of the underlying COPD, but if you can give, it's fair enough, you can still give, and this arrhythmias can be suppressed because beta blockers are best agent for automaticity. So the treatment of automaticity is with treat the underlying cause. So you have to treat the sympathetic overactivity, like you have to treat the digitalis toxicity by either a phenytoin or FAB. We know that there are antibodies that fragment FAB, they are known as, or the ischemia. Sometimes even the ischemia can cause automaticity, thyrotoxicosis or COPD. So you have to treat the underlying cause in a automaticity. So before I go to the triggered activity, I'll just sum up once the automaticity. So important thing about the automaticity are the automaticity is due to the phase 4 diastolic repolarization, and the phase that is usually contributed in the SA nodal cell by the calcium. So anything where the sympathetic activity increases, it will increase the automaticity, and parasympathetic system decreases the automaticity. Second thing is most of the arrhythmias like the sinus tachycardia, ectopic atrial tachycardia, multifocal atrial tachycardia, or it be a paroxysmal atrial tachycardia. So this can be due to the automaticity. Third important thing is it is not due to an extra stimulus like APC and a VPC cannot induce a automaticity. It gets initiated by itself, and that is why there is a warming up period and there is a cooling down period. That is the most important thing which you should know about this arrhythmia. So Now let's go to the next important thing, which is the triggered activity. I think triggered activity is something which most of you will be knowing because it is related to the phase 2 and phase 3 of the cardiac action potential. The phase 2 is because of the equal potassium exit and calcium influx, whereas the phase 4 is because phase 3 is because of the calcium exit of the potassium exit out of the cell. So let's discuss about this triggered activity. Now, what is the triggered activity? Yeah, it is caused by a trigger causing the after depolarization to reach the threshold potential of the cell, and a new action potential is generated. So here, because of the various effects, like either be a drug like a class 1A or class 3 drug, or a hypokalemia or a hypomagnesemia, patient with acidosis or hypoxia, or any other drugs. So these are the various things which cause a early after depolarization, and because of this thing, the cardiac action potential is prolonged. Now, because the cardiac action potential is prolonged, there is a prolonged repolarization, and because the repolarization is prolonged, it can cause the harmful effects. So triggered activity is more likely to occur when the action potential is abnormally long. Now, because of this, because of various factors like a patient with a long QT syndrome, or the drugs that act on the action potential like the class 1A drug or the class 3 antiarrhythmic like the amiodarone, dronedarone, sotalol, all of these drugs increase the action potential, QT interval and the action potential. Similarly, so the triggered activity can be because of early after depolarization or delayed after depolarization. Now, what happens when there is early after depolarization? It can be during the phase 2, that is the augmented opening of the calcium channel, or it can be phase 3 due to augmented opening of the sodium channels. So it can be early after depolarization or late after. The most important thing is the late after depolarization is because of the the complete repolarization. Now, because of the complete repolarization, if during that period the calcium level increase, now we know that the various causes of the calcium level increases because of the sometime in patient who have excess catecholamine, that is in patient with catecholaminergic polymorphic VT, or in the vicinity of a myocardial infarction, there because there is inhibition of sodium potassium ATPase which cause increased calcium channel, or due to increased adrenaline levels of various reason, or in patients with right ventricular outflow tract VT, that is the RVOT VT. So these are the various things which causes the phase 4, that is the delayed after depolarization. Now let's discuss this one by one. Now, in the early after depolarization, as you can see that phase 1 and phase 2, any factor, let it be class 1A drug, class 3 drug, or let it be hypokalemia, hypomagnesemia, acidosis, hypoxia, any of this thing can increase the duration of phase 3 action potential, and the cardiac action potential prolongs. Now, because the repolarization is prolonged, it can lead to Brady-induced various cardiac arrhythmias. So it is the Brady, that is because of the prolonged QT which is very harmful, and it causes the further various arrhythmias. Now, next thing is the delayed after depolarization. In the delayed after depolarization, what happens is, this is the here is the phase 4. Now here the calcium influx increase, and as the calcium influx increases, we know that there is sudden increase in the resting membrane potential, which is like this, will become like this, and it start discharging. So the resting membrane potential, which is normally of SA nodal cell, is around -60. It can become further towards the upper positivity side, and so that will cause a further early firing of the pacemaker cells. So this is one important thing which happens. Now, as I already told you, the triggered activity due to early after depolarization can be because of various reasons like the hypokalemia, hypomagnesemia, bradycardia, or like the class 1A antiarrhythmics or a class 3 antiarrhythmics. Apart from that, the delayed after depolarization is because of a increased calcium level or increased adrenaline level, patient who are on inotrope or catecholaminergic polymorphic VT, or it because even a digitalis toxicity can, because it inhibits the sodium potassium ATPase, it causes increased release of calcium ion, and that causes a delayed after depolarization. Now this is the various conditions which can cause early after depolarization. As I discussed with you, hypokalemia and hypomagnesemia. Hypokalemia, it decreases the potassium channel activity, and that is why it causes the prolonged action potential. Hypomagnesemia increases the calcium channel activity. Hypoxia again increases the sodium channel activity, and acidosis decreases the potassium channel activity. Apart from this, class 1A drug, we know the class 1A drug includes the quinidine. This class 1A drug usually increase the effective refractory period and increase the cardiac action potential duration, whereas the other classes of drug, either it decreases the effective refractory period, and class 1C 1C has neutral effect on refractory period. So it is the class 1A, like the quinidine, which increases the refractory period and cause the potassium channel blockade. Class 3 drugs, as you already know, sotalol, amiodarone, dronidarone, or even ibutalide and dofetilide, this increase the action potential duration. Apart from that, we know that various antibiotics are there, which were even in the COVID time. We know that things like hydroxychloroquine and all, it increases the QT duration. So we should be very careful for their use. Drugs like antihistaminic, like the older class, first generation antihistaminic, fexofenadine and all, and the macrolide erythromycin antibiotic like the erythromycin and all. And apart from that, various congenital long QT syndrome, which you will be, there are many class 1 to class 8 and more long QT syndrome, which can cause the long action potential duration. So if somebody asks you in the exam, they may ask you via MCQ, what are the various causes of early after depolarization which causes a prolonged QT. So you should know the list of this which causes the prolonged QT. Now this is one typical example, as I already told you. This is something known as a ventricular flutter. You can see it's a very here you can see the narrow sinus rhythm, and just the sinus rhythm you can see that there is a beat which falls into the during the repolarization phase, and here the arrhythmia has started. So it forms a torsades point. The torsades point just means that there is a twist around the axis. That is the QRS complex. It twists around its own axis, and that is why it's known as a torsades point. So this is one of the arrhythmia which is due to the early after depolarization, and it is because of a long QT. So that is one thing which we should know. Now, as I already told you, the delayed after depolarization is usually after the completion of the full repolarization, and it is due to the increased release of increased intracellular calcium. So whatever condition where the calcium is increased, like a digitalis toxicity, it inhibits the sodium potassium ATPase, and it causes the release of calcium from sarcoplasmic reticulum. Second thing is catecholaminergic polymorphic VT. Again, it causes the increased accumulation of calcium. Ischemia in its vicinity can cause inhibit the sodium potassium ATPase and cause the increased release of calcium. And then we have a RVOT VT. RVOT VT and ischemia induced VT. There are the two types of VT which is usually due to triggered activity phenomenon. There are many VTs which are because of the re-entry, like the myocardial ischemia. Many myocardial ischemia VTs are even due to the re-entry. I'll discuss in detail in the next thing. So these are the various other causes of delayed after depolarization. Now this is one of the things you can see, that catecholaminergic polymorphic VT. You can see the typical example of the this is a bidirectional VT. You can see the QRS is there are alternate axes of the QRS. One is full superior and one there is an inferior axis. So this is known as a bidirectional VT. There are 3 to 4 typical examples of a bidirectional VT. You know, one is a typical digitalis toxicity. Again, the mechanism is the same. It causes the sodium potassium ATPase inhibition. Calcium increases inside the cell, and it causes a bidirectional VT. Catecholaminergic polymorphic VT. Again, it causes increased calcium inside the cell, and it causes a polymorphic VT. The third thing, there is one of the poisoning known as the aconite poisoning. It is a herbal thing, ACONITE. So aconite poisoning itself can cause a bidirectional VT. So these are the examples of a bidirectional VT. I think even they may ask you in MCQ which of these are the causes of bidirectional VT. So you should remember this, and this is due to delayed after depolarization. Now, again, to sum up, the arrhythmias due to the delayed after depolarizations are: one, which increases the calcium overload; second, which it is exacerbation by tachycardia, like the RVOT-VT and all, and it is enhancement by sympathomimetic, like again the RVOT-VT or a catecholaminergic polymorphic VT. So this is about the triggered activity mechanism. Any doubt is there? I'll again just hold it for a minute and then we'll proceed.
Sir, regarding the absolute refractory period in the ventricular myocyte, phase 0 is absolute refractory period. Phase 2 and phase 3 are whether effective or relative refractory period. Is there anything like that, so that early after depolarization can be explained by those drugs?
You can see this image?
Yes, sir. Yes.
So this is the absolute refractory period is almost till the beginning, just at the up to the phase 2. Apart from that, it is the effective refractory period. After that, there is a relative refractory period. So in the relative refractory period, as I already discussed, stronger than the normal stimulus may be able to depolarize it.
Yes, sir.
Okay.
Yes, sir. Yes.
But this absolute and relative is more related to the electrophysiology part. It doesn't have much impact on your mechanism of the arrhythmia.
Okay, thank you.
This mechanism will only involve when you discuss the ECGs, and then you have to, as I already am telling you, the various ECG, every mechanism in coming in each of these ECGs. Okay, so
Yes.
yeah. So I already summed up both the early after depolarization and the delayed after repolarization. Now let's come to the re-entry mechanism. Now I won't make it very complicated. You should just remember one thing. During the normal activities, can somebody get mute off there? Okay. So we know that in a normal heart or a normal electrical activity, there is nothing known as re-entry. So re-entry is a special circumstance where some people may have two types of pathway, that is the fast and the slow pathway, and because of the various factors which I'll discuss, the re-entry occurs. In a normal heart, in a normal electrical activity, only a fast pathway is there, and the fast pathway conducts all the electrical activity from the AV node down to the ventricular myocyte. Now most of this fiber electrical activity, once it reaches the ventricular myocyte, it dies off. That is, most of this myocyte will get depolarized. However, sometimes some of this myocyte isolated fibers are not fully activated, and then what happens, once they recover, they tend to excite themselves. So this is one thing which we should know, that it is only a special circumstance and not all the patients will have. So that is why we do not see atrial fibrillation, atrial flutter, AVNRT, those type of thing in all the patients, because all the patients won't have this circuit. And that is why this process is known as we call it various things like a re-entry or the circus movement or the re-entrant excitation, echo beats. So I'll just discuss. So now you should know that this is the first slide which shows that in a normal heart, we have only the fast conduction. That is, from the SA node to the AV node, it goes via the fast conduction. The fast conduction, the property is that though it is fast, it has a longer refractory period. The fast pathways have a longer refractory period, and the slow pathways are not present in the normal circumstance. Now, suppose we have a various type of re-entry. That is the micro re-entry or a macro re-entry. We know that we have in atrial fibrillation something known as a micro re-entry, because there is a microfibrosis. Because the atrias are dilated, we have microfibrosis, which forms a wavelet theory, and they are all the micro re-entry. Most of the atrial flutters are the macro re-entry, but they can again also be the micro re-entry. So let's discuss this. So what is the prerequisite of a re-entry is, one, we should have a substrate. So there should be a presence of a myocardial tissue with a different electrophysiological property, conduction and refractoriness. This is the most important thing. So there should be a substrate, and in, like we know in AF that we have a microfibrosis. In atrial flutter we have something cavo-tricuspid isthmus. So there is something that atria is dilated. We have a substrate. Then there should be area of block. We know this is in a in a re-entrant, this is the area of block. The center point is the area of block. Third thing is there should be a unidirectional conduction block. I'll come to it. There should be a unidirectional conduction block. There should be a slowed conduction. There should be a fast conduction, and there should be critical tissue mass and an initiating trigger. Now let's go to this thing. Now normally what happens is, suppose there is an electrical impulse which comes. Normally we know in a normal circumstance this electrical impulse will go from the fast pathway, as we normally happens. This normal fast pathway has the high refractory period, and that is why it takes a longer time to recover. Now, so it will go from here and it will go from here to the ventricular myocyte. This is a slow conduction pathway, and that is why the conduction won't happen from the slow pathway. So that is one thing you should know, that there the slow conduction in the unblocked path. Now next what happens is, suppose there is a premature stimulus. Now this is one important thing which is you should know. A re-entry should always involve a extra stimulus. It can be atrial premature beat, it can be a ventricular premature beat. Now what happens is, the normal conduction, suppose there is a ECG and there is a premature beat. Now before the premature beat, whatever QRS is, whatever beat is there, it goes from the SA node to the SA node, it goes down. Now once that goes down, there is a premature beat. Now because it has gone down, now this fast pathway is in a refractory period. Now because it is in a refractory period, the stimulus cannot go down through it. So that is why now the premature beat will go down through the slow pathway. Now slow pathway has a shorter, though it is slow, the refractory period is very less. Now it goes to the slow pathway, it goes towards the ventricular myocyte. So this, it takes this route, and sometime by the time it takes this route, the refractory period of this fast pathway will get over. And because the refractory period is getting over, it goes again back to the SA node. So it forms a circus movement. I think you understood. So I'll go just tell again. Normal case, what happens is, suppose one normal beat is there, it goes down through the fast pathway, and then once it goes down through the fast pathway into the ventricular myocyte, it goes to the refractory period. Now suppose there is a premature beat, that is a fast normal condition. What happens if there is no premature beat? Once this is over, by the time the next beat starts, this refractory period is over, so the conduction can again start from the here. But in this case, because it's a premature beat, the fast pathway has not recovered from the refractory period. It goes via the slow pathway. It goes both in this direction. It goes in this direction. When it is going towards this direction, the fast pathway, the refractory period is over, and that is why it again goes to the SA node via the fast pathway, and it forms a circus movement. So this is known as the re-entry mechanism, and that is what I told. It needs a substrate, it needs an area of block. It can be anatomical, it can be a functional. One unidirectional block is needed, as I already told you. In the fast pathway, there is a unidirectional block. A path of slowed conduction, that is in the slow pathway as a slowed conduction, a critical tissue mass, and the initiating trigger. The atrial or a ventricular premature complex will be an initiating trigger in this case. So this forms a re-entry. Now let's the most important one of the mechanism of the re-entry is AV nodal re-entrant tachycardia. We know that there are various activities. It can be AVRT or it can be AVNRT. In AVNRT, what happens is, in the AV node itself, between the SA node and the AV node itself, they form re-entry. It forms a circus movement, and that is what the AV nodal re-entrant tachycardia is, which is the narrow QRS tachycardia. Now we have a AVRT, that is atrioventricular reciprocating tachycardia. Here we have a bundle of Kent, something like a bundle of Kent or a Mahim fiber, mostly a bundle of Kent. The most common bundle is the bundle of Kent, where we have an accessory path. Now we know that in a normal heart, the normal conduction goes via SA node to AV node to bundles via the. Sometimes the atrial conduction can go to the ventricle via the accessory pathway. Now we have two types of accessory pathway, that is the orthodromic and the antidromic. Now normal condition, the most of the time it is the orthodromic. Most of the time most of these pathways are usually concealed. Means they do not manifest. So only rarely it is concealed. So in that way, that time we have both the orthodromic and antidromic tachycardia. The antidromic is very rare. Orthodromic is little more commoner than the antidromic. So as the name suggests, the orthodromic means from the SA node to the AV node, it will go from the antegrade approach. It goes antegradely from the SA node to AV node. But the retrograde pathway, this is the accessory pathway. It goes via the accessory pathway. So the normal is the fast conduction. It goes from the SA node to SA node, AV node, ventricular myocyte from the normal pathway. While the accessory pathway, it goes the retrograde direction. And that is why, because the SA node to AV node and all, it is the antegrade pathway, it is a narrow QRS tachycardia. Now coming to the antidromic. Now as the name suggests, the antidromic. So the normal conduction is the opposite. So the normal conduction, the ventricular to the atria is happening in a antidrome, that is via the normal pathway. So from the atria to the ventricle, it comes via the accessory pathway, and that is because it comes from the atria to the ventricle via the accessory pathway. It is a broad QRS tachycardia. That is why you get a delta wave, you get a slurring of the QRS and all, because it goes via the accessory pathway. And the accessory pathway, it is a slow conduction in the accessory pathway. That is the most important thing, because of which it is a broad QRS tachycardia. It is not a very common tachycardia which you should know. Most of the time it is a revealed conduction. It is not a manifest conduction. Now coming to the one important properties of this re-entry is, they are induced in the EP lab by programmed electrical stimulation. We know that when always the patient may not have a APC or a VPC. So in the EP lab, we give something known as a extra stimulation, so to induce this tachycardia. As compared to the re-entry, as compared to the automaticity, which has a warming up and cooling down period, they have abrupt onset, abrupt offset, and the RR intervals are regular. That is one. And it can be reset and entrainment by pressing. I am not going to this detail because they are very in deep. There is something known as the entrainment. Entrainment is just nothing but what happens is, suppose this arrhythmia is occurring at a rate of 150. Now again I put a temporary pacemaker and start pacing at 200. Once I start pacing at 200, now this arrhythmia will start pacing at 200. So once it starts pacing at the 200, the arrhythmia's rate will become 200, and this enters this entrainment enters this circus movement, and so that it can inhibit this arrhythmia. This is also one more way, and that is known as resetting. So this arrhythmia can be resetted by a entrainment. So that is what the entrainment. You drive the arrhythmia at a rate higher than the normal rate, so that the entire circuit can stop off. So that is one important thing. I am not going into detail, but because this is too much of an electrophysiology. Now, what are the various re-entrant rhythm is? As I already told you, AV-NRT is a very typical example. Then we can have AVRT. It can be orthodromic, which is a narrow QRS, and antidromic, which is a wide QRS tachycardia. Atrial fibrillation and atrial flutter because of the macro and the micro re-entry are because of re-entry. And ventricular tachycardia in the context of underlying ischemia is an example of re-entrant rhythm. Now, there are two types of re-entry. It can be anatomic or it can be a functional. So, where does the anatomic re-entry occur? One is WPW syndrome. We know in that WPW syndrome, we have an accessory pathway, and that is the anatomic re-entry. All AV nodal re-entry, all the AV-NRTs, because they have the dual AV node, it tends to have a anatomic re-entry. Most of the atrial flutters and atrial fibrillations are the functional re-entry. Some of these atrial flutters can be because of the anatomic re-entry. Some ventricular tachycardia can have anatomic re-entry, and the ventricular fibrillations can have anatomic re-entry. Functional re-entry occurs in the some example in cases of a MI. In MI, in the infarct border zone, we know because of the ischemia, the different myocytes have different heterogeneity in the conduction time, in the refractoriness. and that is why here the re-entry occurs. So it is a functional type of re-entry. Again, the ventricular re-entry in a patient with uh, uh, ventricular re-entry tachycardia caused by re-entry, it is most common in patients with ISD. And then it is why the surviving myocardial tissue is separated from a normal tissue by it has a different heterogeneity in conduction time, refractoriness. Another example of re-entry is a bundle branch re-entrant VT. It can be a left bundle branch re-entrant VT or a right bundle branch re-entrant VT. It is mostly seen in patients with normal coronary, not in ischemic heart disease, and in patient with dilated cardiomyopathy. Now, this is not so important. The re-entry can be normally what I showed you is a closed circus movement, or it can be a figure of 8 re-entry. So it can be VT, which is caused by non-re-entrant mechanism, is usually seen in patients without CAD, and triggered activity. It is usually seen in RVOT VT, which is delayed after depolarization, and early after depolarization, it is the torsades D points. So those type of VT, that is a polymorphic VT. Now the treatment of re-entry. Now, how do you treat this re-entry? You have to eliminate the excitable gap in the circuit. So how do you eliminate the excitable gap? You give the drugs to accelerate. There are two things. Either you have to accelerate the conduction, or you have to prolong the recovery time. One of these things you have to do. So either you give a drug to accelerate the conduction in the circuit, or you give the drug to prolong the recovery time. Third is, I already told you, do overdrive pacing. Put a temporary pacemaker and pace at a rate more than the arrhythmia rate. It will do the entrainment and it will reset the arrhythmia. Then you give the DC shock. What happens when you give a DC shock? Normally, what happens in a VT or a VF? Because the different myocyte will have different heterogeneity in the conduction time and refractoriness. The heterogeneity loss in all of them will be homogeneity is formed, and that is how these arrhythmias are terminated. All the heterogeneity forms the homogeneous, all the refractoriness, everything becomes the same, and that is how DC shock works. Or you do a RF ablation in one of the circuit, either in AVRT or a AVNRT. Now, this example you can see here. There is a this is here you can see. There is a atrial premature complex. Now, because this atrial premature complex is in the absolute refractory period, here it has not initiated a arrhythmia. Now, here you can see the atrial premature complex is it's not in the absolute refractory period, so it has started an atrial flutter. So this is how the re-entry works. Second down thing is also the same thing. So it is sudden onset and sudden offset. One of the ECGs which I had told you in the first mechanism, that is automatic. It is a cooling up and warming up and cooling down. Now, various supraventricular tachycardias are due to the re-entry. So, various mechanisms like the enhanced automaticity. I already told you, sinus tachycardia, multifocal atrial tachycardia, and an accelerated idioventricular rhythm. Accelerated idioventricular rhythm is one of the reperfusion arrhythmia, which is due to this automaticity, and that is why I told you this is one of the important thing to know. Then we have a micro re-entry. Micro re-entry is seen in patient with paroxysmal atrial tachycardia or a reciprocating junctional tachycardia. It can be a micro re-entry. And then we can have a macro re-entry in patient with atrial flutter or a atrial fibrillation. Now, what happens when you do a carotid sinus massage? So the effect of carotid sinus massage is very important. In a patient who has a sinus tachycardia, if you give a carotid massage or if you give adenosine, it will not make any difference, or maximum what will happen it will transiently come down and it will again come back to its normal rate. Now, what happens in a patient with atrial flutter? In a patient with atrial flutter, it is a macro re-entry. When you do a carotid massage or when you give the adenosine, what happens if the rate is very high and you give adenosine, it will produce a transient AV block, or what it can do is it will bring out the flutter wave. It can bring out the flutter waves. Third is AVNRT. In a patient with AVNRT, most of the time, 95% of the time, the carotid massage or adenosine, it will cause the suppression of the AV node, and that is why it terminates the arrhythmia. So you can see this is a narrow QRS tachycardia, mostly a atypical AVNRT. and here you are given a carotid massage, and that is how it has terminated with a P wave. So that is why it is a very important. So a sinus tachycardia with a carotid massage or adenosine, usually it won't make much difference. You may be able to bring out a P wave, but then again it will go back to the sinus tachycardia. In atrial flutter, if you give, you may be able to bring out the flutter waves, and you will be able to terminate a AVNRT. The most important thing is we give carotid massage in both AVRT, AVNRT, but it is the response of the AVNRT which is the best with the carotid sinus massage and adenosine. Even the AVRT do respond, but their response is not as good as the AVNRT. So these are the various atrial arrhythmias that I told you. Here you can see, here you have given a carotid sinus massage. This is the first strip, a lead V1 strip, atrial tachycardia, focal atrial tachycardia. It doesn't make the carotid sinus massage doesn't make much difference, except it brings out the P waves very clearly. In a atrial flutter, if you give a carotid sinus massage, you can see all the flutter waves are very clear. Now these are the various ventricular rhythm. So we know that accelerated idioventricular rhythm is one of the things where it is because of the enhanced automaticity. Micro re-entry, if a ventricular arrhythmia is because of the re-entry, it is usually in the underlying ischemia, in a patient with underlying ischemia. And macro re-entry in a patient that is a torsades V points or a ventricular flutter and fibrillation. Now this thing is slide is again just telling important thing, like as I already told you, in a patient with automaticity, a premature stimulus cannot initiate it and cannot terminate it. This is one line which you should know. A premature impulse cannot initiate it, cannot terminate it. Whereas a re-entry, it always need a premature stimulus for initiation, and can usually be terminated by a well-timed premature, but it is not always needed. Triggered activity can be initiated by a premature, but may not be needed. And the vice versa is also true. For the termination also, rarely they need a premature stimulation, but for the initiation also, they do not need it. So it is important to differentiate a re-entry from a automaticity, a premature stimulus. Now this is one important slide which is there, which tells you the difference between a re-entry and a automaticity. Now suppose you have a arrhythmia. On the top shelf you can see arrhythmia where so top shelf you can see that there is arrhythmia where there are there are normal beats and then there are a premature beat. You can see the coupling interval before each normal beat and the VPC. We have a coupling interval. Actually, this is a typical example of an interpolated ventricular premature complex. So the duration between the VPC and the preceding normal beat is same. So that is the coupling interval is same. So there are identical coupling interval between the each premature beat and the normal beat, and that is a typical example of a re-entry. So if you see such type of circumstances, you can know that the mechanism is because of the re-entry. Example as opposed to the down ECG, which you can see there is a VPC, there is a normal beat, there is a VPC normal beat, but after some time the next VPC has come, and here there, because it is in the absolute refractory period, it is not able to produce a VPC, and so the next normal sinus beat is come. So if you see the coupling interval, it is not constant between the preceding beat and the VPC. So that thing tells that the mechanism is because of the enhanced automaticity. So one is a re-entry, another is an enhanced automaticity. So this is one key thing to diagnose the based on the premature beat mechanism. Again, this is the electrophysiological side. I won't go into the detail, but again I'll reinforce the premature stimulus is needed for a re-entry. It is not needed for a automaticity. A termination by a premature tells it is due to a re-entry and not because of the automaticity. One important thing in this slide which tells is that the morphology of the first beat. So if you have a sinus rhythm which is going and the first arrhythmia beat, the morphology is identical. Morphology of the first beat is identical to the subsequent, then it is because of the automaticity. And if it is different from the subsequent, means the first arrhythmia beat and the next arrhythmia beat, if the morphology is same, it is the automaticity, whereas if it is different, it is due to re-entry. Again, adenosine in a patient with automaticity, it is usually produce no response or transient slowing. Re-entry, it produces a AV block. In AV-NRT, it terminates the arrhythmias. In others, there is a variable response. In triggered activity, it may be able to, like the RVOT, VT and on, it may be able to terminate, but not all the arrhythmias it will be able to terminate. Catecholamines, as I told you, increase the rate of automaticity and increase the rate of delayed hyper after depolarization. So that is the few things which you should know in this ECG. Now, this is again some of the arrhythmias and their mechanism. As I told you, sinus tachycardia is because of the normal automaticity. Inappropriate sinus tachycardia is again because of the abnormal or the enhanced automaticity. Sinoatrial nodal reentrant tachycardia is because of the re-entry. Atrial tachycardia. Now there are two things. Atrial tachycardia, ectopic atrial tachycardia is due to enhanced automaticity. Atrial tachycardia, like paroxysmal atrial tachycardia with block, is due to triggered activity due to delayed after depolarization. Whereas the intra-atrial re-entry is because of the re-entry mechanism. Atrial fibrillation is mostly a re-entry mechanism. Very rarely it can be triggered due to pulmonary vein potential. Atrial flutter is always a re-entry. AV-NRT is always a re-entry. AV-RT is always a re-entry. AIVR, which you see most of the MI where reperfusion arrhythmias is there, it's due to abnormal automaticity. Similarly, VT, if it is due to in the peri-infarct zone, as I already told you, is because of the re-entry. Catecholamine independent, if it is a VT, it is due to automaticity. So, and if it is due to a torsades D point or a RVOT VT, it is because of the triggered activity. Similarly, digitalis toxicity induced VT are because of the triggered activity. So VT can be because of all mechanism. Atrial tachycardia can be because of all mechanism. RVOT VT is because of the triggered activity. Bundle branch re-entry VT is because of the re-entry. And this is what I told you about MI. So in the vicinity of the MI, the fibers have a different heterogeneity of the refractoriness because of acidosis, hypoxia and all. COVID and cardiac arrhythmias is another session. Now, I'll just stop it for 5 minutes. If any doubt is there, I'll just ask before going into the brief of antiarrhythmic drugs. Sanket, anything?
Sir, in re-entry tachycardia, if AV node block occurs, then it will be whether the arrhythmia will be terminated or not.
Pardon? Re-entrant. AV
node. Re-entry arrhythmias, whether AV block, if there is AV block, if you give AV blocking drugs, then it will get terminated.
Yeah. Like the adenosine, like the beta blockers, like the calcium channel blockers.
Yes, sir. But in the table, they have given no response for AV block.
That is, it means it's written no, but it's a variable response. That is why I didn't tell like that. Most of the
even triggered activity also will get terminated by AV blocking.
Activity by delayed after, mostly of the delayed after depolarization, like the RVOT VT, catecholaminergic polymorphic VT, those by calcium channel blockers and not all.
Okay, thank you.
That is why I told it is important to know the mechanism. Why? First, each ECG will have a mechanism. Second, each ECG will have a mechanism which will tell you the treatment of that arrhythmia. Right. So let's discuss in the next 5 to 10 minutes about the anti-arrhythmic drug. So we know that this classification was given by Vaughan-William classification. There are 4 classes of anti-arrhythmic drug. That is class 1. Class 1 is the sodium channel blocker. Now class 1 has 3 types of drugs. It can be 1A, 1B and 1C. 1A has a moderate blocking effect on sodium channels, and these drugs are the quinidines and the procainamide, which we do not use much. 1B are the weak sodium channel blocker, and they include the lignocaine and the maxilitine. 1C have a strong sodium channel blocking action like the flecainide and the propafenone, which we use in atrial fibrillation and all. Now, So this about the class 1 drug, the important thing is class 1A, it increased both the it increased both the So you can see class 1, it increased both the effective refractory period and the action potential duration. So this is one thing about the bad thing about it is it increases both the action potential duration and it makes affect to the QT. The QT may get prolonged by these drugs. So that is one important thing. Second, about the class 1 agents are they have an anticholinergic effect, and because they have an anticholinergic effect, sometimes all the side effects of the anticholinergics can be there in this drug. Then we have class 1B where the lignocaine and mexiletine. One important thing is lignocaine is usually given to treat the arrhythmias because of the in the MI setting and all. Second thing is it causes the decreased ERP and action potential duration is decreased, and that is why the QT prolongation never happens with this drug. And because QT prolongation never happens, it doesn't cause things like torsades V points and those type of side effects unless the amiodarone and all. Class 1C neither has any effect on effective refractory period, and so it doesn't affect the action potential duration. So 1C are usually neutral drug, and that is why we can safely give in patients with atrial fibrillation like the flecainide and the propafenone. Now, because these drugs have anticholinergic action, they can increase the heart rate suddenly. They do not have vagotonia action. They can suddenly increase the heart rate, and that is why where the atrial fibrillation can turn it into atrial flutter, ventricular fibrillation and all. This is the reason why most of these arrhythmia drugs, when they are given like the flecainide and the propafenone, you should ideally give a beta blocker or a calcium channel blocker before this drug. Why? Because they have an anticholinergic effect, and they can suddenly increase the nodal rate, and that is why the rate AF can progress to VF and VT, and that is why you should always give a drug like beta blocker and calcium channel blocker before giving flecainide and all those drugs. Now, second is class B is beta blocker. Beta blockers are usually we do not use much as an anti-arrhythmic agent, but there are two mechanisms by which they act. One is they decrease the slope of phase 4 depolarization. Second, they prolonged repolarization at the AV node. At the AV node, it causes a prolonged repolarization and it decreases the slope of phase 4 depolarization. And this is the same way where your calcium channel blocker also works. So they prolong the repolarization at the AV node, they slow the rise of action potential. So these are the two mechanisms as compared to the class 3 agents. So the class 3 agents are the your beryllium, ibutylide, dofetilide, and your amiodarone, dronidarone. Those drugs, which prolongs the action potential duration by increasing the effective refractory period, and that is why they are harmful. They can cause a QT prolongation and torsades V points and all. So this is about the mechanism of this drug. So these are the various drugs which I told. Recently they have added 2 more classes, like the class 5 involves the funny current. We know the ivabradine acts on the funny current. Ivabradine, though it is usually used in the treatment of inappropriate sinus tachycardia, we also can use it in the treatment of atrial tachycardia. But we should know that it can precipitate atrial fibrillation and should never be used in patients with atrial fibrillation. Adenosine digitalis, we know we can use adenosine in a patient with AVRT or AVNRT. Digitalis is not a very commonly used drug. So these are the various drugs which have various effects. And this is a table from a brown world. This is how the various drugs act on various mechanisms.